Welcome to this session entitled New Horizons in Primary Care, relating to improving the diagnosis of ovarian cancer. I'm delighted to be joined by two key people in the field. Willie Hamilton, a family doctor, a general practitioner, recently stopped working in clinics because he's very busy as the Professor of Primary Care Diagnostics at the University of Exeter in England. And he has a long and successful interest in improving cancer diagnosis. Dr. Garth Funston is also a family doctor. He works with the University of Cambridge and Cambridge's Primary Care Cancer Group and is undertaking his PhD on the evaluation of tests for detecting ovarian cancer in primary care settings. We're an all UK panel, but you may or may not know that the UK lags behind other similar countries with comparable health systems when it comes to 1 year survival for ovarian cancer and other forms of cancer. So early detection has become, thankfully, an area of increased research and interventions, and we'll hear more about those in a few minutes. But first, Garth is going to update us on his latest research on perhaps the oldest, cheapest, and perhaps most accessible tool to detect ovarian cancer in the GP toolbox, the CA125 blood test. Over to you, Garth.
So many thanks, Francis. I'm delighted to be able to be here and to talk a bit about some work we've been doing recently looking at the use of CA125 to pick up ovarian cancer in women with symptoms in primary care. So I'm sure many of you will have come across CA125 before. It's cancer antigen 125. It's used around the world as a test to monitor women with ovarian cancer who are undergoing treatment. But in some countries, it's also used as a test to investigate women for ovarian cancer when they present with symptoms such as bloating, abdominal pain, or distension. And it's not used in all countries, but it's recommended in quite a few, including the UK, Ireland, and Australia as well. Now, for me, the key question is if we're going to use CA125 in symptomatic women, how good is it? And CA125 has been studied extensively in screening trials in apparently healthy women, and also in the specialist setting in women who are about to have surgery due to a pelvic mass. But actually, it's never really been studied before in women with symptoms who are going to visit their GP. So before the study, we didn't really know how good it was in symptomatic women, and that's what we set out to address. So we performed a study using anonymized records from over 50,000 women who had a CA125 test performed in England in primary care. And of these women, around 1% had ovarian cancer. Firstly, if we look at what proportion of ovarian cancers the CA125 test picked up, and this is at the standard threshold that's used for CA125 in most places around the world, 35 units per ml. And when we used this, we found that 77% of women with invasive and borderline tumors, so ovarian cancer overall, if you like, were picked up by the CA125 test. And if we just focus on invasive cancers, which is the ones we really need to pick up as early as possible to improve outcomes, we found that 85% of women had an abnormal CA125 test. And the test performed better in women over 50. So in older women and women over 50, it was around 90% of women the CA125 test picked up. So that's all very well, but as a GP and as a patient, I think the key question is often, what does an abnormal CA125 test actually mean in terms of your chances of having ovarian cancer? So when we looked at this, we found that across all age groups, 1 in 10 women had ovarian cancer, but in women over 50, where most cancers occur, that was 1 in 7 women with an abnormal CA125 had ovarian cancer. And I know this session focuses on ovarian cancer, but I just wanted to share one other thing which we found really interesting, and that was that 1 in 5 women with an abnormal CA125 who are over 50 actually had another form of cancer, so things like pancreatic cancer and lung cancer. So CA125 isn't a test for these cancers, but it may be useful in signposting the presence of these cancers. So one thing we found looking at the data from this study was that the chances of a woman having ovarian cancer varied massively depending on their age and depending on the specific CA125 value. And so we went on to do some modeling. This allowed us to work out the estimated probability of a woman having ovarian cancer at any age and any CA125 level. So using age 70 as an example and a CA125 level of 50 units per ml, we can estimate that this woman has a 5% chance of having ovarian cancer. We haven't made this tool, but I think it would be great to develop something simple like this and also to integrate it into GP IT systems so as it can be used. So I think there's kind of three key messages from this research. Firstly, CA125's had a bit of a bad reputation in the past as a test for ovarian cancer, but I think this research demonstrates that in symptomatic women visiting their GP, it performs reasonably well as a test for ovarian cancer. It's not a perfect test, but I think it's reasonably good. I think one thing we could do is actually use it in a better way. So by integrating the CA125 level with age, we can work out the woman's chances of having ovarian cancer and possibly make better decisions about referral and further investigations. I think lastly, we also have to remember that high CA125 level can be caused by other cancers. So if it's not ovarian cancer, we may want to think about these other types of cancers which may be causing that high CA125 level. Many thanks.
Thank you, Garth. Very interesting, and I think very positive news in terms of CA125. You mentioned there that only 1 in 10 with an abnormal CA125 might have ovarian cancer, but that's well over the threshold for referring in England, isn't it, for suspected cancer? So it is a really positive thing.
Yeah, absolutely. The threshold in England is 3%, and this is 10%. So it's much higher than that. Yeah.
So Willie, can I turn to you? This is an important set of findings about ovarian cancer, isn't it?
It's absolutely crucial because of the symptom profile of ovarian cancer that we've already discussed in the last half hour, that there are just so many possible ways ovarian cancer can present. And it is so useful for a GP to have a simple, inexpensive, patient-friendly test that can be performed in the surgery that can tease out which of the women with these symptoms are at genuinely higher risk of ovarian cancer. There's an English expression of that you have to kiss an awful lot of frogs to find a happy prince. Well, you do with women with these symptoms, and the way to kiss the frogs is to do a CA125.
Yeah, that's very important. And it compares well, say, to things like a chest X-ray for lung cancer.
Absolutely. That the performance characteristics, that's the scientific term for how well a test performs, is pretty well exactly the same, if anything slightly better than a chest X-ray. There are fewer false negatives, a false negative being where a woman has the cancer, but the test is negative, and that can obviously mislead everybody, particularly the woman, as to what's going on.
And Garth, do you have any reassurances for those women who have a normal CA125, but actually there is something wrong? Is there anything that you've seen in the research?
Yeah, so that thought occurred to us. CA125 isn't picking up all the cancers. So what happens to women with a normal result who do have cancer? So we dug into that data a bit more, and we found that the majority of women with a normal CA125 test who did have ovarian cancer were actually picked up with relatively early disease. And that could be because they often have less aggressive tumors. So as we saw, CA125 is more likely to be raised in aggressive tumors and less likely to be raised in some of the less aggressive tumors. So I think it's reassuring in the sense that if women have a normal test, they're often picked up reasonably early in terms of the disease. So although we would like it to perform better, it provides some reassurance for using CA125 for those women.
Yes. And of course, having CA125 or having access to CA125 isn't necessarily a given, but you've looked at the guidance that's available in countries around the world. And it's really important that countries have good guidance for their family doctors, for their general practitioners. Can you tell us a little bit more about what you found?
Yeah, so in part of the work up to this study, we wanted to look at what's done around the world in terms of testing. So we looked at guidelines from, I think, around 10 countries, 18 guidelines. And the approaches really did vary quite dramatically in terms of the tests recommended, the way the tests were used. So ultrasound is another kind of common early test for ovarian cancer, and some countries recommended using that, some countries recommended using CA125, some countries recommended using both. But I think the thing which really stood out was some of these decisions were made because there wasn't the evidence there to say which test to use. So I think now that we're building this evidence, hopefully we should see kind of stronger guidelines in terms of those evidence and possibly more consistent guidelines.
And Willie, if I can turn to you, you've been involved in some of the Be Clear on Cancer campaigns in England, where the NHS England, Public Health England put out messages about cancer, and that has now included work on persistent bloating, one of the most common symptoms of ovarian cancer. It's important, isn't it, to have in place the good guidelines and access to the right tests when you're doing this type of work. What other lessons have you learned from those campaigns?
Yeah, thanks, Francis. I mean, the campaigns are by and large working, and we haven't actually got a full evaluation yet of the ovarian cancer campaign, but in other cancer sites, the Be Clear on Cancer campaigns are encouraging patients with the right symptom to see their family doctor, and encouraging the family doctor to take investigations and to move it forward. And you see increased numbers all the way down the diagnostic pathway. And I have no particular reason to think that ovarian cancer will be any different. What can be difficult with public awareness campaigns is if you bring them in, but there is no test available for the doctor to do. So if a patient came to see me in the GP surgery with a symptom of cancer and I had no test I could do, it's actually worse. I have to acknowledge, yes, you might have a symptom of cancer. Should I be sending you to a specialist? And the whole stakes get terribly high. So the timing of Garth's work and the timing of the NICE guidance that encouraged use of CA125 is a really good foundation to support an awareness campaign, so that the woman comes in, and I would like the woman to say to me, actually, I'm worried. I saw this campaign. I think there's a small chance I've got ovarian cancer. And then she and I are on the same page. And we can investigate. And following Garth's work, we can be pretty pleased to have CA125 to do as an initial investigation.
Yeah. So it is, you do want to see patients coming in. We sort of get the opinion or the feeling sometimes that doctors don't want people to go in. But if you are worried, go in and say.
Yeah, I mean, of course, I want people to come in if they may have cancer. Equally, of course, on a Friday night, if I have 20 people in, you know, I'm kind of keen to get home. But I mean, there's a balance here. And if a woman is genuinely concerned that she may have a serious disease, of which cancer is one, yes, she must be in. And yes, I hope I will take her seriously. And if it is even Friday night and she's my 21st patient, I still have to take her seriously.
Yeah, absolutely. We ran a little sort of questionnaire before the event to some women around the world and had some responses. And I think they're very telling of the whole challenge of diagnosing ovarian cancer in particular. So, well over half said they weren't aware that their symptoms could have been ovarian cancer, even though they actually felt something was quite seriously wrong. The average time to diagnosis was 5 months from the little group that we had, and that ranged from a couple of days to 2 to 3 years. But the ones who were picked up quite quickly, of course, were the ones who had the obvious symptoms. So something where you could actually feel something in the abdomen, or they had postmenopausal bleeding, which isn't particularly a sign of ovarian cancer, but can occur. But it's the clusters of symptoms, isn't it, that's a real challenge. There's really sort of feeling full, needing to wee more frequently. It's those blend of symptoms that seem to be challenging.
Yeah, that's right. To start with your first point, that many women considered themselves possibly to be ill, having an underlying disease, but couldn't put a label to it. They didn't think of the possibility of ovarian cancer. That's partly a GP's job. A family doctor has to recognize, could my patient have something serious wrong with her? And then the second stage, after, if the answer to that is yes, is, and what could it be? And that's where the cluster of symptoms, or the more obvious symptoms that your panel of women have described, makes my job easier. If she comes in and describes postmenopausal bleeding, to be honest, it's quite easy. I've got a well-ordered pathway I can do. If the poor woman has actually experienced abdominal pain, or urinary symptoms, or slight bowel changes in their bowel, or their early satiety, that's much more tricky, because there are so many non-ovarian cancer conditions that I have to also think of. So I think the crucial thing is it's a partnership between the woman and the doctor. Many women come in and feel, once they've come in the door, it's the doctor's responsibility to take this forward. It's not, it's still both. And I have never the slightest concern if a patient says to me, I think I'm suffering from condition X. That's great. We're on the same page. We can talk about condition X. It may not be.
Yeah, that's a very important thing. And this is where I want to introduce work that you've been doing in recent years. If you could perhaps explain to us about the ERICA trial right from scratch, because most people will not have heard of it outside of England.
Absolutely. It starts with us back in yonks ago, nearly 15 years ago, where we patterned out the symptoms of ovarian cancer and could put numbers on those symptoms so that we could say for single symptoms over pairs of symptoms what the risk of cancer was. In this trial, we have integrated that into software embedded in the GP surgery, so that if a woman comes in describing the symptoms of ovarian cancer and they add up to a risk of ovarian cancer greater than 2%, this will set off an alert in the GP's screen. It'll pop up in the corner and it'll say, Willie, this woman may have an ovarian cancer and the risk is X% based on her symptoms. And I will then, I hope, discuss it with her, and it's quite possible I'll go ahead and do a CA125. We're doing this in 530 general practices around the UK. We've got the first 400 recruited. We actually pull the lever and go live at the second half of this year. It will take a couple of years just to get the results because it's a big, big trial. But I think it will tell us once and for all whether this this mechanism of identifying women early, coupled with the CA125 ability, will allow us to diagnose ovarian cancer at an early stage. That's what we really want, is to improve the stage, because we all know late stage ovarian cancer is much harder to treat than early stage ovarian cancer.
Yes, I mean, we've had some questions in and comments in on the platform. One was about asking, when will we know about the evaluation of the bloating campaigns, and does it, when will we know if it has diagnosed more cancers and diagnosed more early?
Yeah, that's in the hands of Public Health England, and that's a body that's being disbanded at present in England. They were advertising for some of the awareness campaigns. I've been involved in lung and in hematuria, and there's whispers that ovary is the next one on the block, but that's about as far as I know. To do the evaluation takes about 6 to 7 months. So once someone fires the starting pistol, then it's 6 to 7 months after that. So the earliest is going to be at the end of this year, but I can't, it's not my decision, so I can't honestly say exactly when it'll be.
Yeah, but there is there hopefully will be formal evaluation along the way. Garth, we just had a quick question that I wanted to put to you, somebody from the audience. Do we know why some women do have a normal CA125? And also in your work, did you look at women with BRCA mutations or a history of symptomatic women, or the history of symptomatic women? Just a quick answer on those would be great.
Yeah, so take up the BRCA question. We didn't delve into that because we're using routinely recorded data from GPs, and things like BRCA mutations aren't recorded perfectly. So we didn't focus on that. We did delve into the symptomology a bit, and it was the symptoms that you would expect patients to have. So the most common one was abdominal pain and discomfort, were patients with pelvic masses, but that was much less common. And the first question you asked again, sorry, can you just repeat that?
Why would somebody have a normal CA125?
Sure. So patients' CA125's levels vary in healthy women, so the level can vary from individual to individual. But things which can make it more likely to be normal are if the disease is very early. So if you've got earlier cancer, it's more likely to be normal. And also certain types of ovarian cancer. If you dig down into the different types, things like high-grade serous, quite an aggressive form of ovarian cancer, it's more likely to be positive in high-grade serous and less likely to be positive in things like borderline tumors and mucinous tumors. So it depends a bit on the type of ovarian cancer as well.
Yeah. We were talking with Willie there about the ERICA trial. Would you, as a GP, practicing, jobbing GP, would you welcome tools like that in your practice going forward to help, so that the sort of computer popping up and saying, Dr. Funston, might this be ovarian cancer?
Personally, I think I would. I think, especially if there's evidence that they work, which Willie's working on at the minute, if he can show that, then I think it's kind of a game changer for me. They can be really helpful if they pop up and it's something you haven't thought of. Sometimes if you have lots and lots of them popping up, you can get what's called prompt fatigue. So that is a risk. So we've got to be careful in selecting which ones we use in practice and make sure we're using the best ones we can with the best evidence behind them. But I think if we can show they work, without question, I would welcome them, yeah.
Okay. Coming back to you, Willie, some of the examples that we had coming in before the meeting were about, these odd clusters of symptoms. Some people call them vague. They're not really vague if you have abdominal pain or if you have bloating, but that's what the clinical community tend to call them because they're not specific. But we had people here then being referred on, or if they got referred, they got to refer to one specialist, then they got sent back to their doctor, then they got sent to another specialist, then they got sent back to their doctor, and they had to see multiple people over some period of time. In England, there are new mechanisms now for trying to speed up that portion of the diagnostic pathway. Would you like to explain a bit more?
Yeah, sure. Before I do, I'm going to just pick you up on the word vague. I know your community has used that. I think we medical community should step away from it, because the word vague to some extent means, and I don't believe you. Whereas I think these symptoms are very rare and very important, and I much prefer the term non-specific. So by all means, let your community use the words they use, but I don't want the medical community to be using the word vague. Excuse the rant. Now, thanks, Garth. Not to come back to your proper question, in England we have established rapid diagnostic centres. There's, I think, about 60 of them have now begun. I should know, I'm on the panel that set them up, but it's about 60 of them. And these are for people with non-specific symptoms, which may represent cancer. And if it's cancer, it's not clear what the site is. And about 30% of cancers in this country present with a symptom profile that could represent 1, 2, or more cancers, as opposed to the very specific cancer symptoms like a breast lump, which is breast or nothing else. In a rapid diagnostic center, there's both specialist nurses and specialist medics, and they have all the various tests on tap. So they can immediately decide whether a woman needs a transvaginal ultrasound, or she needs a pelvic CT, or she needs some form of fancy investigation that can be done there and there. So it's effectively a one-stop shop for diagnosis of possible cancers. And the yield is quite high. The current figures are that 7% of patients being sent to a rapid diagnostic center transpire over cancer of some form or another. I can't remember the breakdown of ovarian. It's obviously that's a small component of the 7%.
But their pathway was shortened considerably by having this type of approach.
Yeah, and they have avoided being the, what I call ping pong patient, if you don't mind the sporting thing of me hitting the ball over the net, it bouncing back, here's a negative test, me hitting the ball back over the net again, another specialist says it's a negative test, and the poor woman just bounces from one place to another, ghastly, knowing she's ill, and yet nobody quite getting to the bottom of it, and that's ghastly. For her. And so this idea that you can use one door to answer that is much better.
Yeah, we have just a couple of minutes left, but we can't not mention the words COVID-19 and the impact on diagnosis. What would your messages be to patients to be out there, to patient advocacy groups about the importance of getting symptoms seen?
Yeah, the NHS is open for business. I think some patients are frightened to attend general practice. It's that frightenedness is dropping as vaccination takes off. Now, I know you've got an international audience here, and vaccination's much more advanced in Britain than it is around the world. But certainly in Britain, the NHS is open for business, and particularly with CA125 and to a lesser extent transvaginal ultrasound still being available. Most women can be properly assessed before seeing a specialist. Against that, the number of 2-week wait referrals, that's the urgent referral for investigation, has dropped off across pretty well all the specialties. So there are some people out there and some women with ovarian cancer symptoms who've not come to see the doctor or who've not been referred. Please do come in. It's business as normal. And
research has shown that delays do matter, don't they?
Oh,
delays
by
do
gum
matter.
they do. Yeah, they definitely do. And there is research across other cancers, of which ovarian was only one, suggesting that for every week of delay of a cancer diagnosis, the prognosis, that is the chance of survival, reduces by about 1%. Now, it doesn't make many weeks to get 1% stacking up.
Yeah, absolutely. I'm afraid that's all we have time for this session. Thank you both so much, Dr. Garth Funston and Professor Willie Hamilton. In the briefing paper that was sent out with the joining instructions, there are links to their research, and I do encourage you to go and take a look. And thank you both so much.